lectureship was started in 2016 by generous support from Kessler family to promote education for healthcare providers with focus on chronic diseases. I wanted to acknowledge Mr. Neil and Craig Kessler for their tremendous support and help. This lectureship provides us with a great opportunity to invite an expert in the field to learn from. Now, with great pleasure, I would like to introduce our Kessler visiting professor for this year, Dr. Tuhina Neogi. She is a world-renowned expert in the field of osteoarthritis and gout. She did her medical school at University of Toronto and went to complete her residency and fellowship from there. She moved to Boston in 2003 and has risen up the ranks at Boston University to become the section chief of rheumatology in 2019. She also completed her PhD from Boston University in 2009. Dr. Neogi has close to 250 peer-reviewed publications and book chapters. She has served on several critical organizational committees across our field, federal government, and mentored many next generation of rheumatologists and scientists. Thanks, Dr. Neogi, for taking time out of your busy schedule to be with us today. Now, without further delay, I'll pass stage to Dr. Neogi. She's going to discuss about osteoarthritis in 2020. Thank you and welcome.
Great, thank you. And thank you for the kind invitation. I'm sorry this couldn't be in person, but hopefully next time. So I will just go ahead and share my screen and pull up my slides here. I'm really delighted to be able to speak to you today about osteoarthritis and with a specific focus on what's new. These are my disclosures, and importantly, I was on the core executive for the ACR Arthritis Foundation treatment guidelines that I'll be reviewing today. The learning objectives, I believe, were sent out, but we're going to talk about the methodology behind treatment guideline development, review evidence-based recommendations for OA management, and start a conversation about individualized approaches to management of OA. So first, by way of brief background, sorry, I'm just going to minimize some stuff at the top here. I apologize. Okay, so I'm going to first start with this reviewing osteoarthritis epidemiology. According to the latest global burden of disease estimates, over 500 million people worldwide have osteoarthritis, reflecting about 10 to 15% of adult populations worldwide. We know that the knee is one of the most common sites of pain and symptoms with regards to osteoarthritis. And in the US, in the prior 30 days, about 30% of adults state that they've had knee pain. We know that pain increases over time and that patients with osteoarthritis experience fluctuations in their pain symptoms. But eventually the pain becomes much more severe and is quite persistent. In terms of the impact of osteoarthritis, as of 2015, according to the National Ambulatory Medical Care Survey, joint pain and arthropathies were the #1 reason for doctor's office visits. So this is more prevalent or more common than things like going to the physicians for hypertension, which was previously the most common reason for ambulatory care visits. Now, clearly, patients don't go to their physicians for their blood pressure because they feel something. They go because the physicians are asking them to come back for a BP check. So from a patient perspective, what's really driving them symptom-wise to the physicians is their joints, and osteoarthritis is obviously the most common condition that's affecting their joints. Musculoskeletal pain is the second leading cause of disability worldwide in terms of years lived with disability. And again, osteoarthritis is a large contributor to that. And then perhaps most surprising to many people in the audience will be the fact that osteoarthritis is the third leading hospital admission and discharge diagnosis in the US. This is third after child-related births and sepsis-related hospitalizations. So for a general medical audience, you would think that cardiovascular disease is going to be a much more common hospital admission and discharge diagnosis than osteoarthritis, but it is not. And the reason is because of joint replacement. So we have a huge burden on the healthcare system because of osteoarthritis. We know that the impact of osteoarthritis is largely driven by the symptoms. So pain is the primary clinical symptom of osteoarthritis. And because people are living longer with knee osteoarthritis, they're living longer with those symptoms and the burden. Unfortunately, we have very limited management options available, and this includes medications that have minimal efficacy, minimal to moderate efficacy and concerning side effects, and relatively efficacious management options such as weight loss, physical activity, and physical therapy are woefully underutilized. And in fact, from a primary care physicians' perspectives, the referral to PT and advice regarding physical activity is probably in the range of about 10% for osteoarthritis, for patients with osteoarthritis. And then joint replacement is considered the definitive treatment for osteoarthritis, yet still about 20 to 30% of people have persistent pain after their knee replacement. And clearly we don't have enough orthopedic surgeons in the country or the world to deal with this huge burden of osteoarthritis with increasing prevalence. So what are the current treatment options for osteoarthritis? Well, we have in this management landscape the adjunctive modalities, the physical and mind-body modalities, so diet, exercise, weight loss, etc., which, as I mentioned, is woefully underutilized. We have analgesics like anti-inflammatories and acetaminophen. Duloxetine is FDA approved for the management of osteoarthritis, but not widely prescribed, partially potentially related to the side effect profile. There are topical agents, including diclofenac, which there's now an OTC formulation, and topical capsaicin, and then there are intra-articular injections. So given the limited number of options, I think we need to think about what are the consequences of those limited options. And so in some work that I did with a junior faculty member at our institution, Andrew Stokes, we looked at NHANES and the prescription medications prescribed by providers for people with arthritis and low back pain. And again, the bulk of arthritis is osteoarthritis. And so in the blue line are opiates, and in the orange are exclusive non-narcotic analgesics. So that's primarily NSAIDs and COX-2 inhibitors. So you can see in the late 90s and early 2000s, there was sort of a steady rate of NSAID and COX-2 inhibitor prescription, and then there's a marked decline. And then that sort of remains steady and then declines further. And when we see this stark decline, there's this gradual increase in opioid prescribing. And so what happened here? Why was there such a tremendous change in prescribing habits? And so for those of you that have been in practice long enough, you'll recognize that this is around 2004, and this is when Vioxx came off the market because of cardiovascular concerns. And so with the cardiovascular concerns, of COX-2 inhibitors, the concerns about NSAIDs as well, with regards to cardiac effects, renal effects, GI effects, were also being increasingly recognized and addressed. Now, as one stops or decreases prescriptions of NSAIDs and COX-2 inhibitors, what happened? Well, opioid prescribing increased because people continue to have pain. And so this is perhaps one of the unintended consequences of having inadequate options for managing a condition as prevalent as osteoarthritis. So in summary, the scope of the problem: over 500 million adults are affected globally, representing about 15% of adult populations worldwide. We have a substantial cost burden, with osteoarthritis reflecting costs of hundreds of billions of dollars annually, greater than 900,000 hospitalizations annually. And then the lack of effective therapies are contributing to disability, diminished quality of life, and potentially contributing somewhat to the opioid epidemic. So now I'm going to move on to evidence-based management and frame this with a case of a 54-year-old woman who has bilateral knee pain. She has pain going up and down the stairs, and when she sits for a prolonged period of time, she feels that her knees stiffen up. And so for those of you who are Zooming from home or from your office and you're sitting for an hour, some of you may experience some of that stiffness, and that's very common in osteoarthritis. Now, the primary care physician did order an x-ray, and it's not necessary to order an x-ray, but you can see here there's like some osteophytes and some osteophytes here and some minimal joint space narrowing on the medial aspect. And so on further questioning, you elicit further information about that gelling phenomenon that she's experiencing. She does describe some locking of her knees, but she's not had any actual buckling or falls. In terms of her physical exam, her BMI is 34 and she has some medial joint line tenderness. From her labs, the pertinent lab is at a creatinine of 1.7. So with this in mind, I'm going to move on to talking about the evidence-based management options in the context of guideline treatment development. So the osteoarthritis landscape for guidelines, there's a number of different organizations that have published guidelines, including the American College of Rheumatology and Arthritis Foundation, which was recently published in February of this year. And there were also ORSI, Osteoarthritis Research Society International guidelines that were published a few months prior to that. And the two guidelines are largely compatible with one another. So I'm going to focus primarily on the ACR guidelines. So the prior version of the ACR guidelines were published in 2012 with the update done in 2019. And the ACR has a very formal process by which guidelines are developed with this on their website, with defining the project scope, identifying the important clinical questions and outcomes, public comment on that plan, conducting the literature review, developing the evidence report, and considering the evidence report in conjunction with the clinical experience, and then drafting the recommendations. Then that goes for peer review, and then finally the guideline is published. And then there's a regular update so that when there's sufficient number of new studies available, then a decision is made about updating the guidelines. And the ACR guideline development uses the grade methodology. So just as a very high level illustration, you first develop all of the clinically relevant questions in the formulation of, formulated as PICO questions, patient intervention comparison outcome. So you generate a whole host of these questions, and then there's feedback, and that's whittled down. For each of these questions, we look at outcomes, and we define outcomes as being critical, important, or not important. And outcomes that are not important do not move on to the literature search stage. After the literature search, there's an evidence profile that's created that summarizes the findings and estimate of effect for each outcome. And each of these are then rated for the quality of evidence as high to very low. And the quality of evidence can be downgraded for a number of issues such as risk of bias, inconsistency, indirectness, imprecision, publication bias, and can be upgraded if there's a large effect, dose response, adequate control of confounders, etc. So this grading is provided across all of the outcomes based on the lowest quality of critical outcomes. So if there are two critical outcomes, such as in this example, and one critical outcome had high quality of evidence, but the other only had moderate quality of evidence, then that whole PICO would be graded as moderate. This whole evidence report is then sent to the voting panel that reviews it and meets in person to develop the recommendations. So the recommendations are formulated as for or against in terms of direction, and then strength is in terms of strong or conditional. And these considerations, or these recommendations, are based on considering the quality of evidence, balancing the benefits and harms, values and preferences, and if necessary, also cost. So I'm just going to go through that, these kinds of definitions, because I think it's really important when looking at recommendations, understanding what strong versus conditional means. So a strong recommendation means there's a compelling evidence of efficacy and that the benefits clearly outweigh the harms. So in the setting of a strong recommendation, we expect that the voting panel is confident that the desirable effects outweigh any potential harms and burdens, and that this recommendation would apply to all or almost all patients, with only a small number that would not follow that recommendation. Now, very few recommendations are strong in any guideline because we don't have randomized controlled trials for the highest level of evidence for every single clinically important question. And this is particularly a challenge in rheumatology generally, and in osteoarthritis in particular, where there aren't a lot of clinical trials that have positive effects. And rheumatology trials generally are done in a sort of a much, are not done as frequently as you might have cardiovascular trials. So we don't have a lot of high quality evidence to support every single clinically important question that we may have. But we do believe that guidelines should be actionable, should provide actionable recommendations. And so in the absence of a randomized clinical control trial, what is the best other evidence that we can use to guide the recommendations? And it's those instances where it's often a conditional recommendation because of the quality of evidence. So in terms of the strong recommendations against, it's a similar principle. There's a compelling evidence of lack of efficacy and or the benefits do not outweigh the harms. So for the ACR OA guideline development project, we developed 52 PICO questions for the hand OA, and 110 for the hip and knee. And as I mentioned, these were just published recently in both ANR and in Arthritis and Rheumatology and in Arthritis Care and Research. So first, before getting into the details, I just want to provide some sort of philosophical framework for how we put this together. So you'll notice that there is no mention of non-pharmacologic therapy in our guidelines. And that's because, we really believe that language is important. Language is important for patients' understanding of what we're doing. And non-pharmacologic sounds like non-therapy. It would be like having a guidelines that's labeling for rheumatoid arthritis, non-surgical management of rheumatoid arthritis. The implicit implication is that surgical management is kind of a definitive option. So we've been very careful to avoid the term non-pharmacologic. In addition, we think that the foundation of OA management includes self-management and education principles, and that we have to use physical modalities, mind-body modalities, and therapies that might be topical, oral, or intra-articular therapies. And there's no hierarchy, there's no pyramid. These modalities can be used at any time in the course of an individual's course of osteoarthritis. And given that that individuals live for decades with osteoarthritis, they may need to come in and out of these various modalities and repeat them and revisit some of these modalities, and that the modalities can be used in conjunction. And so a sort of a general guiding principle is that we have to figure out the right puzzle pieces for each individual. So it's not a one size fits all. And so that's the way I talk to our patients about trying to understand which puzzle pieces, which management options will fit together to optimally manage their osteoarthritis. So moving on to the recommendations. So in terms of educational, behavioral, psychosocial, mind-body, physical approaches, the guideline has strong recommendations for self-efficacy and self-management programs, and for weight loss for hip and knee osteoarthritis. And I'm just going to show you an example of one trial that helped inform this recommendation. So this is a trial by Steve Messier and colleagues called the IDEA trial that was published in JAMA a few years ago now, where they randomized people to diet, exercise, and diet and exercise in combination. And what they found was that those that were in the diet and exercise intervention arms lost more weight than exercise alone. And that weight loss itself was associated with improved pain, improved function, faster walking speed, and decreased knee loading. So overall, everyone had pain improvements, but those that had the most weight loss had the most pain improvement. So moving on, there was also strong recommendation for exercise. Now we attempted to evaluate if there was a particular type of exercise that was better than another, or if there could be sort of a hierarchy recommended. But the evidence to date does not allow for differentiation of different types of exercise modalities. So all of these exercise modalities are strongly recommended for osteoarthritis, including aerobic exercise, strengthening, aquatic, and neuromuscular. Now, neuromuscular is also important to help reduce fall risk because people with osteoarthritis are at increased risks for falls. Now, when we talk about exercise, a lot of people don't really know how to talk to patients about exercise. Oh, sorry, that's 2 slides away. But aerobic exercise does not need to mean that someone has to jog. Someone can do low impact exercise that is aerobic, such as shown here with a stationary bicycle or going for a walk. And in fact, daily walking is one of the most important management options for osteoarthritis. There's also a strong recommendation for Tai Chi for the hip and knee OA, and that's because there has been a high quality randomized trial showing benefits with Tai Chi. Now, what I was starting to talk about is, how do we talk to our patients about physical activity? So first we need to understand, what does physical activity mean? So there's 2 types of physical activity. There's one that's sort of part of our daily activities, and that could be any physical activity that we have while working, doing our household chores, active transportation, recreational activities, gardening, and daily walking, as I mentioned, is one of the most important. Now, exercise is something that's planned and structured, and these include those exercises that I showed in that other slide, the strengthening, aerobic, neuromuscular, etc. And the challenge, I think, for many patients is that when they hear exercise, they think they need to go jogging, etc. And what we really need to do is think about very slow graded programs to help them. So maybe they can't do 10,000 steps a day, and there's actually no data suggesting that you need to do 10,000 steps a day. In fact, some of our work has shown that even 6,000 steps a day significantly reduces the risk of having incident functional limitations in people with OA. And so, there's one sort of program that we recommend where if someone's really sedentary, we start at 3,000 steps per day, and then we help them think through gradually increasing it to 6,000, etc. So daily walking is really one of the easiest things that patients can do. We also think about the neighborhood and environment. If they're nervous, and psychologically there's a lot of nervousness about, oh, I might not be able to make it back home, we think about, are there any benches along the way, or can they go to a shopping center where they could be indoors and sit down at a bench, etc., to try to increase their confidence and eventually increase their walking ability. And just the walking alone has impacts on strengthening, aerobics, capacity, neuromuscular training, and also weight loss. So while it's not the same as going to physical therapy for these particular aspects, it is helpful. Okay, so moving on, for additional strong recommendations, cane use, and obviously this is for later stage disease, tibiofemoral knee bracing, and first CMC arthroses all have strong recommendations. And one sort of public health announcement for the cane is that you want to, when you're advising your patients, you want to make sure that the joint that's painful, whether it's the knee or the hip, that the cane is used in the hand opposite to the painful limb, because the cane is supposed to be offloading that painful limb, and they should be stepping forward on the painful limb and leaning on the cane when they're stepping forward on the painful limb. So strong recommendation against. The one educational behavioral, psychological, mind-body, physical approach that had a strong recommendation against it was TENS. And while there are a number of studies that show a positive effect, when you limit it to high-quality trials with low risk of bias, there was really no efficacy. And so that was the one strong recommendation against. I'm now going to move on to conditional recommendations for this category. So there were a number of conditional recommendations, including balance training, and so this is partially, can be considered part of neuromuscular training, yoga for the knee, cognitive behavioral therapy, kinesiotaping, hand orthoses, patellofemoral knee brace, as opposed to tibiofemoral knee brace, acupuncture, thermal interventions, and radiofrequency ablation. Now, some of these do have good evidence for pain, but some of them have not been studied specifically in osteoarthritis. And so that's why they were downgraded in terms of quality of evidence if they're there was some indirectness of the evidence. So cognitive behavioral therapy, we know, is very beneficial for chronic pain, but the studies in OA either weren't done or the evidence from the studies in OA were not as strong. For yoga, similarly, the studies have just either not been done or not as strong. And I'm just pointing out that we say knee here specifically because we do have a recommendation against yoga for hip OA because there is concerns about abduction worsening hip OA. Now, radiofrequency ablation is very promising, and there are some FDA devices or procedures for this, but the concern was that there's not yet enough long-term evidence about safety and sort of long-term effects of radiofrequency ablation. So conditional recommendations against include modified shoes, lateral and medial wedged insoles, massage, manual therapy with exercise, ontophoresis, and pulse vibration therapy. Now, there's a little bit of controversy about massage, and again, this is because the studies in OA have not specifically shown a benefit. So while massage might be beneficial for other things, for OA in particular, we don't have good high quality evidence to recommend it. And the few studies that we had looked at, there was really no efficacy. Now, manual therapy with exercise is a bit controversial and might be counterintuitive, but really no one would do manual therapy with exercise without a whole other sort of regimen of physical therapy modalities. And so that's what that is reflecting. So now moving on to pharmacologic approaches with strong recommendations. So we have strong recommendations for topical NSAIDs for the knee and oral NSAIDs, as well as intra-articular steroid injections for the knee and the hip. But with the hip, the strong recommendation is for imaging guidance for steroid injections of the hip. Other than that, we have a whole list of strong recommendations against. And I'll just quickly read through these. So bisphosphonates, they've been studied in a number of well-done clinical trials with no efficacy shown to date. Glucosamine sulfate and chondroitin sulfate, lots of patients have questions about this. Lots of patients are on these agents, but a high quality, low risk of bias trials have not demonstrated efficacy. Now you'll see for chondroitin, we only have hip and knee listed there, and I'll explain why in a few slides. Hydroxychloroquine and methotrexate have been studied recently in well-conducted trials with no efficacy. Intra-articular hyaluronic acid injections for the hip have been strongly recommended against because high-quality study has shown no benefit. PRP, platelet-rich plasma injections, and stem cell injections have not had really any good quality studies done to recommend them, and not enough long-term studies. So because of the lack of evidence from good randomized trials and concerns about cost and formulations and long-term safety and efficacy, these are strongly recommended against until better evidence can be used to reevaluate these. And then the biologics, TNF inhibitors and IL-1 receptor antagonists, again, good quality trials have been done which showed no efficacy. Now moving on to the conditional recommendations. So for hand OA, topical NSAIDs were conditionally recommended. Now, we know that topical NSAIDs have some efficacy, and the conditional recommendation is simply because of convenience and feasibility, and to apply topical NSAIDs to a number of hand joints and not have it rub off, et cetera, can be somewhat of an issue, but it's only so that's why it's conditional rather than strong. Also for topical capsaicin for the knee, there's some good evidence, but that's not risen to the level of high quality. Intra-articular steroid injections for hand OA is conditional because of lack of direct evidence from studies. There is a conditional recommendation to use intra-articular steroid injections over other injectable agents. And I mentioned I would come back to this chondroitin sulfate recommendation where it's strongly against for knee and hip OA, but we have a conditional recommendation for hand OA because there was one study that was well done that seemed to show a benefit. There's also only a conditional recommendation for acetaminophen because of real sort of lack of good efficacy, but patients felt that they needed an option. And I forgot to mention that the ACR treatment guideline process includes a patient panel, and I'll show you some of the data regarding acetaminophen. Duloxetine was also conditionally recommended. It is FDA approved for osteoarthritis, but there's a lot of data about potential adverse effects, limiting its feasibility and usability. And then finally, a conditional recommendation for tramadol, which this is again a situation where the patient panel really had an impact on the recommendations, where the physicians, which was a multidisciplinary physician group, including rheumatologists and internists and nephrologists, did not want to recommend tramadol, but patients felt that they needed to have an option. Now, going to conditional recommendations against, topical capsaicin has a conditional recommendation against simply because of the potential risk for having capsaicin on the hands and then rubbing or touching another body part. So it can certainly be used, but because of that feasibility issue, is a conditional recommendation against. Opioids, again, here the physicians wanted to have a strong recommendation against non-tramadol opioids, but the patients really wanted to have an option if they had no other options for pain management. Fish oil and vitamin D, there's been sort of mixed studies in relation to their efficacy. Hyaluronic acid injections for first CMC and knee, because well-conducted studies do not show efficacy, but again, people wanted to sort of have an option in case other modalities were not working. Similarly, inadequate efficacy data for intra-articular botulinum and prolotherapy. So there were a number of modalities for which we were unable to make a recommendation because there just weren't data to support making a recommendation. And that includes yoga for hip and hand. As I mentioned, there was concern about yoga potentially exacerbating hip OA because of the movements that involve hip abduction, but there were no studies to base a recommendation on. Topical lidocaine, pregabalin, gabapentin, SSRIs, SNRIs other than duloxetine, TCAs, these all just have not been adequately studied in osteoarthritis. And then finally, the anti-nerve growth factor agents. When we were doing the literature review and the evidence report and review of the evidence, the phase 3 anti-NGF studies had not yet been published. And so we were in the midst of doing this update while the FDA lift the restriction on NGF trials. That lift had been reversed. So the hold had been lifted, but the study outcomes were not yet available when we were putting this together. So I just want to summarize for you, and I don't expect you to read all this, but in terms of physical and mind-body approaches, there's a number of things that have strong recommendations, some that have conditional recommendations for, a couple of strong recommendations against, and a couple of conditional recommendations against. But you can see overall, in terms of the mind, body, and physical approaches, there are a number of potential recommendations for use. In contrast, for the pharmacologic approaches, we have very few strong recommendations, a few conditional recommendations, but a lot of strong recommendations against or conditional recommendations against. And so I think this kind of visually, this kind of heat map that I put together kind of visually illustrates the real dilemma that we have in osteoarthritis, in that we don't have a lot of management options for our patients, and the few things that we do have that are efficacious in terms of pharmacologic approaches, often, for example, oral NSAIDs often have toxicities and adverse events that limit their ability to be used. And for the physical and mind-body approaches, they're woefully underutilized. Now, so many patients sort of say, well, you know, I just want what's going to work the best. And often patients think that medications work the best. But this is a nice summary from different sources showing the standardized mean difference for various treatments. The green dots are the standardized mean difference for pain, and the blue squares are the standardized mean differences for function. And the top half here are considered first line therapies that everyone with osteoarthritis should undergo, including exercise, walking, and self-management programs. The next gray area are sort of adjunctive management options. The blue here is showing a study of a combination therapy of exercise and cognitive behavioral therapy, and then finally pharmacologic management approaches at the bottom. And so you'll see here, the dotted line is a standardized mean difference of 0, meaning no efficacy. And this blue line represents the minimally clinically important differences for pain and function. And so you can see here a lot of these therapies sort of fall along this minimally important difference line. I will point out that they did include TENS in this review, but they did not take the same approach of only looking at low risk of bias, etc. But nonetheless, you can see that exercise, weight management, walking, etc., have similar or even better efficacy than our first-line pharmacologic approaches. So I think this is really important for patients to understand that exercise, walking, weight management, some other things, Tai Chi, etc., might actually have more efficacy than giving them a prescription for NSAIDs or a topical analgesic. So back to our patient. So this is a patient you'll remember. She was 54. She's obese with a BMI of 34. She has a creatinine of 1.7. Bilateral knee pain. And so because of her renal insufficiency, she has used acetaminophen in the past. And now she's interested in learning more about acupuncture, injections, and quote unquote natural remedies. And so in terms of first steps for her, we would think about general best practices. And so while today I'm talking really specifically about the OA treatment guidelines, I just do want to remind people that we need to also have a broader approach to assessing and managing pain. So pain is so multifactorial, and it's very rare that only a single disease pathology is contributing to their pain experience. So I always make it a point of assessing their sleep, their mood, their coping skills, physical activity, etc. Anything else that might be contributing to their pain experience. And so we would assess those things. We'd recommend weight loss and physical therapy. And again, as I mentioned, studies have shown that referral for physical therapy and guidance about weight loss and physical activity are exceedingly low among healthcare providers. In one study, it was only 13% of people with OA got referrals for physical therapy. And in another study, more patients got opiates right away than had referrals for physical therapy or counseling for weight loss and physical activity. So it just highlights how underutilized effective management is. And then in this patient, topical NSAIDs would be reasonable, even with her creatinine, her creatinine of 1.7. Topical NSAIDs have minimal systemic absorption. So those would be two things to do in addition to the general best practices. But now, what about her questions? What about acupuncture, injections, chondroit, and other medications? So I'm just going to go through some of these modalities and try to put into context about how our recommendations came about. So you'll recall, or may not because I went through it so quickly, that acupuncture was conditionally recommended for osteoarthritis. Now, there's a lot of controversy about the efficacy of acupuncture. And when you look at trials that have really used sham control as opposed to some other kind of control, the efficacy is quite limited. We also know that there's a lot of placebo and contextual effects. There was a trial several years ago by Maria Suarez-Almazar who showed that if you randomize people to acupuncture versus sham, and then further randomize them in a factorial design to a very positive, optimistic acupuncturist versus a neutral acupuncturist, the groups that did better were the ones that had the optimistic acupuncturist who spoke really positively about, oh, you're going to feel great. And so there's a lot of placebo and contextual effects. But on balance, given the low risk of harm, it was thought that it was reasonable as a conditional recommendation, given that there's so little to offer for our patients with osteoarthritis, that if they do get some benefit, that would be at a cost of low risk of harm. Now, intra-articular steroids have recently become very controversial. So we know, based on randomized trials, that they do have short-term efficacy. Generally, the effect wanes by about 12 weeks, depending on which formulation you're using. And Tim McAlinden, in a trial in 2017, published in JAMA, showed that there was no long-term efficacy over 2 years of repeated injections every 3 months. Now, one criticism of that trial is that they did not assess efficacy within that 12-week window. And so our patient panel said, hey, you know, if they can get some symptom benefit even in a 12-week period and they have to have a repeated injection, that's better than not having any pain relief even over a short period of time. Now, what the controversy is that in this trial, in Tim McAlinden's trial, there was a potential cartilage finding on MRI. So the treatment versus the steroid injection versus saline injection arm had a 0.1 millimeter difference in cartilage thickness over 2 years. That represents less than a 1 voxel on MRI, and that 0.1 millimeter difference over 2 years, if you were to extrapolate it, that would be about 1 millimeter over 20 years. And that's the difference between going from a Kellgren-Lawrence grade 2 to a Kellgren-Lawrence grade 3. So, you know, we know that OA is slowly progressive, and for patients to get some pain relief, you know, transitioning from KL2 to KL3 over 20 years is actually slower than what many people's natural disease will do. Importantly, this small difference was not associated with any pain or function, so it's unclear what the clinical implications are. Now, many of you may also be aware that there's been recently a case series that questioned whether or not there's any adverse effects of joint steroid injections with sort of rapidly progressive OA. Now, it's a case series, so we don't know if there's confounding by indication. Would those cases of rapidly progressive OA happened even if they hadn't gotten the injection, because the reason they had pain wasn't because of OA, but rather because of some other underlying pathology that led them to seek care. So there's some controversy still, and we need more data about the long-term safety. Now, hyaluronic acid is a little bit of a simpler story. The reason that there is a recommendation against hyaluronic acid is because of high quality data. So in 2 systematic literature reviews and meta-analyses that were done in the last few years, you can see there's a huge publication bias. So, you know, so this is a funnel plot. So, you know, half the funnel plot is missing and 2 separate publications. And so we know that positive studies tend to get published and negative studies tend not to get published, which is sort of what you're seeing here. So there's a huge publication bias concern. And then in these 2 papers, they looked at what's the difference between studies that show no efficacy and studies that show a positive efficacy. And they saw that overall risk of bias, inadequate blinding, and small trial size contributed to those differences. When they limited the trials to those that were large with blinded assessments, the effect size was almost negligible. And further, when they limited it to studies that had only low risk of bias trials, the effect size was 0. In addition, there are some safety signals with flares, serious adverse events, and local AEs. And so for this sort of the totality of the evidence from high quality studies, that's why there's this recommendation against. Now, chondroitin. There's a predominance of negative studies for glucosamine and chondroitin and the combination. So here, this gray zone shows sort of clinical efficacy. Below this will show supplement superiority. So you can see at various durations of studies, there's really, these are really sort of equivalent to placebo. But we did have a conditional recommendation for using chondroitin sulfate in the hand, because there was one hand OA RCT that we were able to find in our literature review that had positive results, low risk of bias, and no risk of harm, no evidence of harm. So, you know, as more studies that are well conducted get done, some of these recommendations might be changed. Now, opioids is very controversial. As I had mentioned already, physicians did not want to have any recommendations. We wanted to have a strong recommendation against opioids. In addition, there was a JAMA meta-analysis last year that showed that for chronic non-cancer pain, the pain efficacy is not greater than the minimal clinically important threshold, and same for function. And so while patients don't want opioids, they wanted to have it as an option because they feel like they're walking this tightrope that they want to manage their pain, but they want to avoid the adverse effects of opioids, and they don't want to be, you know, they're worried about addiction. They don't want to contribute to the opioid epidemic. And so this is, you know, as I said here, kind of like walking a tightrope. And on the other hand, as physicians become more and more concerned about using opioids, there's now a growing concern about a pain epidemic. So we've got an opioid epidemic on one hand, but if we don't have adequate pain management options, then we have a pain epidemic. And there was a really nice viewpoint published in JAMA in the last year or two about this upcoming pain epidemic as fewer physicians prescribe opioids, but we don't have other things that we're referring them to, like physical therapy for pain management, and we don't have other good pain therapies. And then finally, for acetaminophen, we only had a conditional recommendation because we just wanted to have it as an option for patients, but there's really minimal efficacy for pain. Again, this dotted line is the clinical meaningful threshold. So minimal efficacy for pain and for function. And we also know about some toxicities, but we still needed it as an option for people who have contraindications to other therapies. So in summary, the guideline you know, currently has no hierarchy. We'll have to be revisiting these different modalities throughout the life course of someone's osteoarthritis, and we'll need to think about a multimodal approach. And so when thinking about a multimodal approach, you want to think about specifically what is present in your patient and how can you address those things. And again, this is going back to those puzzle pieces. What are the elements that your patient needs to put together a good management plan to improve their symptoms and function? So in summary, you know, I really want to emphasize that physical modalities are really the cornerstone for managing osteoarthritis. Patients don't like to hear this because they want a magic pill, but really we don't have a magic pill. The pills that we have don't work as well as physical modalities. So they have to do a little bit of hard work to help themselves. Really need to think about multimodal therapy. You don't need to think about sequence. You don't need to think about hierarchy. Think about what's going on in the patient and what can you put together for them as an individualized management plan. You want to think about other contributors to their pain. Are they not sleeping well? Do they have depression that's not well managed, etc.? And you want to have realistic goals. You know, I always say that zero pain is not the goal. We're trying to improve their symptoms so that they can function and do what they want and enjoy a good quality of life. That might not mean that there's zero pain. And I hope my little heat map has shown you that we have an urgent need for disease-modifying OA drugs and additional pain management options, because what we do have, while we have a handful of things that are efficacious, it's certainly not enough to manage the 500 million people around the world that have osteoarthritis. And ideally, you know, sort of taking that individualized management approach a step further, we need to really think about mechanism-based approaches to management. What is it that's going on with their particular OA, with their particular symptoms, with their particular function that you can address, rather than thinking about a one-size-fits-all. And with that, I'm just going to acknowledge the funding that has helped support me doing my OA research over the, you know, over this last little while, and I'm happy to take questions.
Thank you so much, Dr. Neogi, for an excellent overview. I'll start with one question of mine, and then I'll read through any questions which come through the from the audience. So I wanted to ask you about intra-articular joint injections. Patients usually prefer, whenever they come into office, if they're having a flare, what they want is injection and fix it. So how frequent you can offer that? And is there any data looking into if there is an increased risk of need or the increase in the patients who receive frequent injections get earlier replacement surgery or progression of their OA?
Right. Yeah, so this is a really important question, especially in light of that a case series that I mentioned from Kompel et al. Published in Radiology in 2019. So right now, the standard is for steroid injections once every 3 months, not based on any specific safety data, but rather the trials that have shown when you assess people very frequently, efficacy tends to wane by 12 weeks. So every 3 months is sort of the rule of thumb still. In terms of adverse effects, there's no long-term studies done to date about knee replacement or further progression. But our group, we do have an ACR poster in which we've analyzed some data with regards to that. We've compared steroid injections to hyaluronic acid injections, but it's a small study. Now, what to do about patients when they come in for flares. If you look at the Compal Radiology 2019 paper, you'll see in that case series, there's a lot of scary looking images about rapidly progressive OA with subchondral insufficiency fracture, etc. As I mentioned in my talk, we don't know what the pathology was preceding those injections. So, did they truly have OA? Because some of the people that they have in their case series were young. I wouldn't have expected them to have OA. So did they have some preceding subchondral insufficiency fracture that led them to seek care because they have pain and then they get an injection? So my rule of thumb is you want to make sure that the pain is typical for their OA. If they have pain out of keeping with what you might expect for OA, you might want to take a second look and see whether or not they have some other pathology going on, and should you avoid an injection. Some of the concerns might be that they might then go in, because the pain is relieved, they go and abnormally excessively load the joint. That can cause a problem. And if they had an underlying subchondral insufficiency fracture, that could potentially worsen it. Jeff Katz has recently published that in a series of people with knee pain and a question of meniscal tear, about 3% had a subchondral insufficiency fracture. So if we're thinking that for OA, we want to recommend exercise, physical activity, etc., with a subchondral insufficiency fracture, the current standard is to limit weight bearing. So, so I think there's a lot that we still need to understand about how to detect subchondral insufficiency fractures. And there's such a low prevalence, it's not sort of financially feasible to image everybody. So, I think you have to use your clinical judgment. Is that pain that they're coming in for, is it typical for OA, or is it out of keeping with OA and I should think about something else?
Thank you. So another question from Dr. Rubinstein. Can you please comment on the use of CBD for the treatment of OA pain?
Yeah, so we did not review the evidence for CBD in the guideline because we've specifically focused on compounds that were available in pharmacologic grade in the US. And so at the time, yes, there's lots of CBD products, but nothing that's pharmaceutical grade, I should say. The Arthritis Foundation has put out kind of a patient information sheet on CBD that people can review, but generally the evidence to date for the types of agents that are either blocking the FAAH pathway through which CBD works, or some others, just have not risen to the level of evidence that we can sort of make a clear recommendation. And I think we don't have enough understanding of sort of long-term efficacy. So certainly patients, will say that they've tried CBD oil and it's all anecdote. Some people say it's helped, some people it says it hasn't. We don't know what the formulation is, et cetera. And we also don't know about long-term systemic absorption. So right now I don't make a specific recommendation for it just because the evidence is not sufficiently robust, and I can't make a recommendation specifically based on the OA treatment guidelines because we were unable to review it. So I see a question here about NSAIDs. So there are really no data to support whether one NSAID is more efficacious than another. And so I think the best approach is to consider the side effect profile. So for example, the precision trial of celecoxib versus ibuprofen versus naproxen, showed a pretty good safety profile compared with ibuprofen and NSAIDs. So that's the kind of scenario that are, kind of considerations that I make when choosing an NSAID. So there's a question about medications known to cause weight gain. Yeah, it's true. You know, I think with anything that is related to osteoarthritis, addressing whatever you can about obesity and weight management, it would be ideal. I guess the question is, how much weight gain are some medications truly causing? And can that, you know, is it truly outweighing, sort of pun intended, the impact of actually taking a reasonable approach to diet and exercise? I also say to patients that even a 5-pound reduction in weight can result in symptomatic benefit. So Steve Messier years ago showed that each pound of load that the knee experiences, it's like 4 pounds of load in translation. So losing 5 pounds, the knee would experience it as though there was like 20 pounds equivalent less load through the knee. So, you know, even small amounts of weight loss can help. And, you know, we also don't know enough yet about sort of the, you know, anti-inflammatory cytokines and all sorts of other things that happen with exercise that can also benefit symptoms.
I think that applies to some of the chronic pain management as well, like gabapentin and Lyrica and those medicines we use right now. They kind of have a side effects of weight gain, and then it can make patients' pain worse while we're trying to help them.
Right, and so I think that's why you need to be thoughtful about why are you prescribing those particular things. And again, just going back to really having a long conversation. Unfortunately, a lot of physicians, we don't have time for these conversations, but that weight management, physical therapy, physical activity will have a lot more benefit and a lot more long-term benefit. What's the word I'm looking for? Like, sorry, I can't remember the word, but it's going to be a much more robust and maintained benefit. Like maintaining musculature around the joint is much more important than over the long term, and will provide relief over the long term in a much better fashion than a short-term few-hour relief with an NSAID.
So I don't see any more questions. Thank you so much for being with us today.
Okay, well, thank you very much for the invitation, and it was a pleasure, and hopefully in the future we'll be able to do this in person.
Thank you so much.
Okay, take care. Bye.